Welcome everyone to another installment of our ClearPoint On-Demand webinar series. For those of you who have just joined us, we will have time at the end of the presentation for Q&A, so please utilize the Q&A function at the bottom of your screen at any point during the talk to submit questions you'd like to have answered at the end. With that, please join me in welcoming today's speaker, Dr. Sanjeet Grewal. Dr. Grewal attended medical school at the University of Cincinnati College of Medicine. He continued his medical studies at the Mayo Clinic School of Graduate Medical Education for neurosurgical residency and completed fellowships in stereotactic and functional neurosurgery, as well as surgical epilepsy. Today, Dr. Grewal has his own neurosurgical practice at the Mayo Clinic in Jacksonville, Florida, with a primary interest in translational science in epilepsy and movement disorders. Dr. Grewal's basic science research explores cutting-edge treatments, including advanced stem cell therapies and new indications for neuromodulation. Dr. Grewal was first exposed to ClearPoint during his residency and fellowships, and continues to use ClearPoint in his current practice for a wide range of applications, including neuromodulation, laser ablation procedures, and biopsies. Drawing on his broad experience with surgical MRI guidance, today Dr. Grewal will discuss his initial experience with SmartFrame Array, our next generation stereotactic frame enabling OR to MR workflows. Please join me in welcoming Dr. Grewal.
Thank you for having me here today. I'm excited to share our experience with SmartFrame. So what we're going to start with is first a basic overview of some of the legal regulations side. And then I have no relevant financial relationships or disclosures related to this talk today. But today we're going to focus on the applications of MRI guidance in functional and stereotactic surgery. We're going to talk about benefits that we've seen using the SmartFrame Array, specifically for laser ablation as well as for biopsies. We'll go through a couple of case presentations, and then we'll open it up for some potential future applications. I think it's important to figure out where we came from before we can really figure out why we're going into MRI guidance. So I think when you look here on the left, you see this initial frame. This is the frame from Horsley and Clark in 1908. This was really used for primate stereotaxis, and it was based on a Cartesian system. This frame was never really adapted for human use with Horsley and Clark. However, Clark in 1918 worked with the Canadian neuroanatomist Mullen to develop the frame in the middle here, still using the same principles. Stereotactic surgery really didn't gain a lot of popularity until 1949, maybe late 1930s, when Spiegel and Weiss started publishing their work. And this is their frame that they were using there, still using that Cartesian system. Which is the XYZ. Basically, we went from Spiegel and Weiss, who really kind of started thinking about the stereotactic and functional aspects in terms of targeting for procedures like Parkinson's disease, to around the same time in France, Talleyrand, and this is what his frame looked like. He's really popularized standardizing the stereotactic systems by the ACPC line, which back then they were using pneumoencephalograms or pneumoventriculograms, however you want to describe them. Most recently in the middle here is the most updated version of the Lexel. I think this is called their Vantage frame, but the real novel aspect of that was using an arc-based system so that no matter where you entered, you could still get to the center of the target. All these were excellent advances in stereotactic neurosurgery, and allowed us to target deep lesions and really explore the telencephalon. But there were still limitations to that, and that's where we come up to the future and why we need to think about that. So I'll leave that as something for you guys to think about, and we'll come back to that here. But when we look at MRI guidance, it's used for a lot of different things. So we can use it for deep brain stimulation, and whether that's for Parkinson's disease, OCD, epilepsy, it's still the same procedure. We can use it for things like drug delivery studies and preclinical studies for stem cell therapies, which is something that we have a particular interest in. You can look for biopsies of small deep-seated tumors. I mean, I think that tumor that we have out there is fairly large, but you can imagine smaller tumors in the brainstem where you really want to make sure that you're accurate within a few millimeters. And laser therapy, whether that's treatment of epilepsy or ablation of tumors or cavernous malformations. But anytime you really want to make sure that you are where you think you want to be, this is an excellent way to do so. So what that means is that you have confidence in planning. So you can preoperatively plan your trajectory and your target. So you're not doing it the morning of. And you're not obtaining those MRI scans, which slow down your workflow during the day of. You can navigate through the vasculature so you can get appropriate CT angiograms or MRI angiograms to make sure that you're avoiding any of the veins or arteries on your way into the target. And depending on the size of the laser fiber you're using for an ablation or the deep brain stimulator electrode, you can do this with a single pass, so you're avoiding multiple passes to the brain and minimizing the risk for deflections using a ceramic stylet and a peel-away sheath. When we look at the difference between a conventional stereotactic procedure, and that's one of the older like cell frames on the left, and the ClearPoint procedure, which is your XG frame on the right, one is image guidance. So we talked about preoperative imaging and fused to a CT versus fusing MRI to MRI with ClearPoint, or just getting real-time MRI if you need it. Patient experience is different. A lot of times for our frame surgeries, we're doing them awake to make sure that we're right on target. With ClearPoint, we can image at the time and identify we're at target, so we can do it asleep. So when we think about the workflow, we kind of think of three different things. One is what we consider the pre-planning or deciding our target as well as our trajectory. Then there's the guiding phase where we're aligning our entry point initially and then our target. And then the confirmation phase, which is our post-insertion MRI. So I think the best way to try to explain these workflows and the differences is to try to show them to you. So what we'll do is we'll start with an XG workflow for deep brain stimulation. This is a case of my mentor, Dr. Robert Warren, who really introduced me to ClearPoint and as well as stereotactic neurosurgery in general. So this initial step is very similar in both workflows. This is placing the fiducials, and then he's using a sharp tip awl to mark his entry point on the skull. He's going to use a little bit of local to numb up that area and then make an incision down to the bone. What you see once you make that incision down to the bone is you see the mark left from the awl, and that's where you make your burr hole. Then you open the dura, which is what he's doing right now. You want to open this really widely for deep brain stimulation cases so you minimize your risk for deflections. What we're doing here is he grabs some of the galea and he moves that superiorly and a similar one inferiorly. And you do this before you mount the ClearPoint tower to ensure that you're not going to have any skin or tissue in your way when you're trying to get to your target. And you'll see that right there, where he's making sure that as much of that burr hole is open and stays open. So, when I was his resident, that was me holding those stitches open. Luckily, I don't have to do that anymore. We now screw those ClearPoint screws in. It comes with 3 screws. We use the 3 rescue screws as well because you're very reliant on that base being secure for the rest of the case. So in our experience, we want to make sure that happens. And once you're in the MRI scanner, you're aligning your trajectory, which we'll see in the next video as well. That's the insertion of the ceramic stylet and the peel-away sheath. And then you confirm that you're where you want to be. Then you remove the peel-away, you remove the ceramic stylet, you leave the peel-away sheath in place, and then you insert your DBS lead down that same tract. Since you've taken your stylet to target, you really shouldn't have any deflection because everything should be preserved within the peel-away sheath at that point. And at that point, you can confirm again with MRI if you want. We typically don't. You remove the peel away sheath, then you lock your lead into place, and you end up closing the skin incision following that. This still is an excellent workflow for deep brain stimulation because you're not really drilling through the tower. So you're not worried about vibrations in the tower or deflections in the tower. It's nice sometimes to have, so those yellow and green tabs there allow you to move your entry point in the X and Y planes. So it really allows you to very precisely control both your entry point as well as your trajectory, because the blue and the orange towers are your roll and your pitch. And what we'll see next is the differences in the ClearPoint SmartFrame workflow. So again, on the left is the SmartFrame XG, which is what we still use for our deep brain stimulation cases, but we've really transitioned to using the array for laser ablations and biopsies. And we'll kind of talk about the differences that we've noted and why we've made that transition. So when you feel this, and this is hard for me to show in a video or in a talk, it's a much firmer, steadier construct, which is very nice when you're locking it onto the scalp as well as when you're drilling through it. There's a lower profile, it's about 2 inches shorter, which means that you're drilling much closer to the skull, which minimizes chances for deflection or sway. There's been studies that show that it's as accurate as XG. And the software for it's very streamlined compared to some of the original XG software. I think one of the other things that people are excited about is that it supports an OR to MRI workflow as well, where you can couple this with your navigation system, so whether that's Stealth or BrainLab or Stryker, and you can basically use this to mount your entry, so you can skip that initial fiducial scan and frame. And if you're going to do a burr hole, you could theoretically do your burr hole, mount your entry all in the OR, and then come to align and insert in the MRI suite. So that can increase your efficiency in doing these cases sometimes. So when we're looking at the SmartFrame Array as well as the software, one of the big differences is the targeting stem. So that entire thing is radio opaque in the MRI, so you can see it, and it's much more precise than the balls that we see in XG. I think this is one of the things that I've used the most is the offset channels. So you have 6 offset channels that are spaced 3 millimeters apart. So when we showed in XG, you had that blue and green ability to alter your entry point. You can basically do a similar thing with these 6 offsets without having to make those adjustments in the MRI scanner. And the software will automatically calculate adjustments based on which offset you predict. And you'll see this multiple times, but it's about 2 inches shorter. So again, you're closer when you're drilling. And there's an OR to MR workflow, which is helpful for certain systems. So this is one of our more recent cases. This is a laser ablation case. So we use an IMRA system. So it's a full MRI workflow for us. Patient's positioned prone. We'll shave a little bit of hair. This is the drape that we use for the system that comes with the ClearPoint system. What we like about using the IMRIS and MR workflow is that once the patient's positioned, they never move. So you're not worried about lines, tubes, anything moving, because the scanner is going to move throughout the case. This is that same alignment grid. I show this case because you'll see here in a second, there's some features in SmartFrame that can help you when you're initially not necessarily right where you want to be. So this is the scanner coming in. And what we see here is that we're actually off the grid just slightly. So when that happens, you can do one of two things. You can reapply the grid, redo the scan, or in this case, what we decided to do is we said, okay, we think we can still approximate where the entry point is going to be. And because we have the ability to quickly change our entry point within those 3 millimeters, that we should be okay to pick an entry point if we're off by a few millimeters. So as you can see, we're really at the edge of the grid, and we're not quite on the fiducials there. But we'll do the same thing. We'll mount the frame. You can see that it's just a sturdier frame. Use an automated kind of striker drill to put our initial 3 screws, and then we'll put our rescue screws to follow. That's a centering screw that we use that keeps everything lined up with that initial entry point. Here's a little local. We'll insert the tower now. And then we kind of pre-align what we think is going to be close. Now, a couple of differences here. One, you can see a much lower profile. Second, you see that whole stem is what's going to show up in your MRI, not just a few of the markers or the balls. You also see that there's not four tabs here. There's just the pitch and roll, because any change in our entry point is going to be made with these offset connectors here. So you'll go into the scanner. This workflow will show you the adjustments you need to make in terms of your roll or your pitch. And you can see we're using an offset channel here, which gets us to our planned trajectory better than using the standard channel, because we were a little bit off from what we expected our entry point to be. You make the adjustments in the scanner and you confirm with orthogonal scans. This is a roll lock. So there's a roll lock here on the top. You can have one at the bottom as well. That's one difference from XG if you're really worried about roll locking. We haven't found the need to use both, but it's a nice option to have. Once you remove that, you have a whole system. So all of these are designed with the offset in place. We make a small incision. We do a stereotactic twist drill hole. Again, what you can see, and especially people who have experience with XG, you can see that there's a lot less chatter. It's quite smooth, and the tower itself is much more rigid, which is nice. And we take the reducing tubes out, then we'll upsize it, which we didn't show here. You have multiple guide tubes that you're going to use. It's a stereotactic coagulator to open the dura. Once we feel like the dura is open and cleared, we'll put the ceramic stylet through. We leave the ceramic stylet in place for a little bit just to create that tract. Remove the ceramic stylet. You change the locking cap for a larger fiber, because we use the Montera system for our laser ablations. So that's their laser. I usually put a few marks on there so that when we're pulling back, since we don't use the robotic guidance system, we kind of have an idea of how far we're pulling back each time. And we'll hold it in their frame. Bring the MRI scan in. You can see you can get very nice precision, get a nice safe delivery, and then do a nice mesial temporal lobe ablation with this procedure. That's just a little bit of our withdrawal. Now, another advantage, because it's lower profile, you can really put multiple towers very close to each other. So this was a laser ablation case where we actually decided, instead of coming supine and coming from anterior, we want it to come from posterior trajectories. And what you see here is that you can really mount these within a few millimeters of each other, and you can basically align them together so that you're not doing multiple stage procedures. You can actually put multiple twist drill holes at the same time and multiple catheters at the same time to increase your efficiency in the OR, which is nice. So similarly here, I think this is something that we were talking about again. The fact that it's shorter allows you to put things closer together. It gives you more stability, and it allows that drilling to be more precise as well. And then as we're going through this, I think this is where we see the future. I think it's important for us to know that the use of ClearPoint for gene therapies or stem cell studies is only when it's approved through a clinical trial. But to be able to accurately position a smart flow catheter where you want it to be, to do it simply and to be able to do it efficiently, I think is important. We've found some advantages using Array to do that. And we will open this up for the future, and we're happy to have anyone visit us anytime. This is our campus here in Jacksonville, Florida, and that's our beach. So when we're not working, we try to have a life outside. Thank you, guys.
Thank you, Dr. Grewal. We just have a couple of questions that have come in. And again, if anyone thinks of anything, please feel free to enter that in the chat. The first one is, how long does the preparation stage for surgery usually take?
So, what I would say is from the time we usually get anesthesia to release the patient, meaning that they're in the operating room and intubated and all their lines are appropriate, to the point that we have our Fiducial on, draped, and are doing our first scan, it's usually about 15 minutes.
And how long, so we have a little bit of a follow, how long does it typically take you to plan, say, for a single trajectory case?
I don't know, Carrie, you've seen me do these. It's
maybe 10 minutes.
Yeah, I was gonna say it's not too bad for a single trajectory case, especially if it's something that's more, not to say straightforward, but more common, like MTLE. Some of the more complex, if you're doing something like insular delivery or you're doing multiple trajectories, that will take longer. And being able to pre-plan that beforehand is really helpful.
Could you clarify? So we have another question. Are you fixating your patients in a skull clamp, or are they resting on the table? So maybe if you could just clarify the head frame that you use.
Yeah, I don't know what you guys call it. Do you know the name of it?
So I'm trying to think if you're using inflection or if you're using our multi-positional head fixation frame. We have head frames for a variety of different applications.
It's like your OG head frame.
Okay. Yeah.
It doesn't
multi-positional head fixation.
Yeah, exactly. But as we were discussing earlier, to use ClearPoint, the patient's required to be fixed in place, correct? So you can't do it without fixating.
All right. One other question. So we have some Array users primarily in the neuro-oncology space that have essentially been utilizing this offset channel feature to create two parallel trajectories. So for example, to avoid having a biopsy void potentially interfere with laser ablation imaging, or to aspirate a cystic element of a lesion and then ablate another aspect of the lesion in the same procedure. Could you foresee a potential utility for this parallel trajectory capability kind of beyond neuro-oncology, for example, to simplify surgical planning, for increased infusion coverage of a target region in a cell or gene therapy trial, or just laser ablate a larger region? Have you thought about that at all?
Yeah, absolutely. I think we all think about that, right? It's similar to that case I was presenting with the laser ablation where we did the parallel trajectories. I think one of the advantage of the arrays is that you can put it really close together and you can run both at the same time, right? So not that you're going to align at the same time, right? But you can align, and then drill, and you can do things in parallel rather than in series. So you can make the case much more efficient. The only thing you have to be careful about there is how long your workflow takes, right? Because if you drill and then you have brain shift and you're not paying attention and adjusting appropriately, you could get into trouble. But I think as long as you're efficient through the process and you're understanding the potential things you need to look out for, I think it's very feasible. And I think it's how most people would want to do it.
Someone else is asking, are you satisfied with the current Fiducial grid workflow, or would you ever consider integrating optical nav for choice of your entry point? It's funny, we were just talking about this before we started.
Yeah, exactly. We were just having this discussion. I think there's certain cases where I think the optical nav could be helpful and make things a little bit faster, at least in our workflow. So for example, in a DBS case, I could see us, because we're doing burr holes, I could see us basically deciding our entry point, making our incisions, doing our burr holes, making the burr holes wide, and then mounting the frames, and then just going to the align phase, right? So that would skip a decent amount of time. But that's pretty much the only thing I can see myself switching to. And I know there's still some kinks to work out in that for our, at least for the IMRIS system that we have. We're still working on how to do that. I think, one of the things that I wanted to show with that array case was, some people have very mobile scalps, right? So even if you think that the fiducials are pretty accurate, they're still scalp fiducials, they're not bone fiducials. So with the centering guide, you think you're there, and then you see it and you're like a couple of millimeters off. That's not unusual. So it's really helpful to be able to quickly readjust that entry point using the offsets.
Great. In thinking about potential future applications like gene therapy or cell therapy trials, could you elaborate a little bit on the potential benefits of the array system for these applications, or maybe just MRI guidance in general in that context?
Yeah, and that goes back to that initial slide where I had the question mark of, why do we care about this, and why is it important for the future? I mean, I think if you're going to be delivering gene therapies or cellular therapies, you really need to make sure that you can accurately identify, one, that you're in the right place, but two, how much diffusion are you getting of these therapies or these cells? And then furthermore, that you're not getting any complications while you're doing it. When you look at traditional frame-based approaches, you really have no feedback, right? So if you're doing the frame-based approach to sleep, you're getting no feedback until you wake the patient up afterwards and get an MRI and see what happens. You can get two-dimensional targeting with looking at, a fluoroscopic thing through the bomb sites, or some people will get three-dimensional confirmation using an O-arm, but you're really not getting any idea of what's going on in the parenchyma, how far things are diffusing, how much things are diffusing if you're having a complication. So being able to have intraoperative MRI guidance is essential when you're doing these things, because you want to make sure that whatever volume you want to deliver, you can show that you did that and that you did that safely.
Great, thanks. And just one last question. In your personal experience, do you feel that the SmartFrame Array has been able to deliver the same level of placement accuracy that you were used to with the original SmartFrame XG?
Yeah, absolutely. I think so. I think the first couple of cases, it took a little bit just getting used to the different software. But once we got used to it, and even those who ended up being accurate, it was a slower process for us for the first couple of cases. But once we got used to it, we really decided to switch all our lasers and all our biopsies to SmartFrame, and we really use XG only for DBS now.
Okay, just kidding. We had one kind of follow-up. Can you elaborate a little bit on what the potential, going back to the gene or cell therapy in the OR when you're kind of blind, what would be some examples of potential complications that you wouldn't be able to visualize if you were doing that type of workflow as opposed to using MRI guidance?
Right. So, let's say you have a tract hemorrhage or a hemorrhage at the target, you won't be able to see it until you wake the patient up afterwards. Let's say, a lot of these patients have that you're doing gene therapies for have some level of underlying cortical malformation or ventricular asymmetry. So, one of the things that's been known to happen in traditional frame-based approaches is that you go through the ventricle and you don't realize it. And even on two-dimensional scans, you think you're in the right target, but you're really somewhere completely different. And you'll never know that. So you could deliver your therapy to a completely off-target area and not be able to tell until you wake up and do an MRI afterwards.
Well, thank you so much, Dr. Grewal. This was a very informative presentation, and I really appreciate you taking the time to be with us here today. And thank you, everyone, for joining us. And thank you for all your great questions.
Thank you, everyone. I really appreciate you guys having us.
Thank you.